everybody.
Mm-hmm.
Got it.
Good evening, everyone. Hello, hello. Welcome to tonight's town hall featuring Michael Sequeira, MD, Public Health Officer for San Bernardino County. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. We're really happy to see all of you online with us tonight. This is our second in the series of these public health town halls with our superstar, Dr. Sequeira. And once again, Dr. Sequeira will be covering a lot of ground, including updates on COVID, vaccinations for adults and children, as well as boosters. And he'll also be discussing epidemics in our region, such as syphilis. And he may talk a little bit about reporting requirements and the opioid crisis, but we'll see. Dr. Sequeira is going to see how far he can get. And then following that presentation, we're looking forward to taking your questions at probably around 7 or a little after. We invite you to submit your questions on the chat feature on your Zoom dashboard. And we're going to keep admitting people here. Mm-hmm. And if you'd like, you can use your raise hand icon to ask your question by voice. We can make it a little more interactive as well. But just go ahead and enter your questions as Dr. Sequeira is speaking, if you'd like to do that, and we'll get to them all once the presentation has concluded. Mm-hmm. So, all right, before we introduce our star of the evening, we would like to invite Dr. Ken Lane, who is past president of SBCMS, as well as a member of our Inland Wellness Information Network board. And he's on mute. You're on mute, Dr. Lane. We'd like to invite Dr. Lane to make a really quick comment. There, you're joining us now, Dr. Lane.
You know, I love the word quick. So today I contacted Allison and we had an emergency. San Bernardino Valley College football was told they are done for the season. Okay. They had one positive test and everybody else tested negative. And I called Allison and she referred me to Heather Cockerell, who was amazing, Michael. She was amazing. Within seconds, she sent me the information from California Public Health and the testing that had to be done at day 5 and day 7 and so forth. And all of that had been done. And now San Bernardino Valley College is going to play on Saturday. Mm-hmm. Heather is taking on the school districts. And I actually asked her if she was going to get a raise. So she's amazing. And she saved San Bernardino Valley College football. Thank you.
Thanks, Ken, for the great feedback. And wow. Yeah, I mean, and the schools are a whole.
Schools are huge. Are you kidding?
My God, it's an issue. And we've actually, we're a little bit hands off with the school district, and we're allowing the school district to handle their own contact tracing, and we've given guidelines.
But Heather is amazing. She's a great staff person.
She is. She knows her stuff.
Yeah, she knows.
We discuss problem cases all the time, and actually, the private schools actually they're on their own pretty much, and it's been difficult, and we've had to go up to 10,000 feet and help them manage their outbreaks. But
Heather's amazing.
Interesting. Heather is.
I'll mute for the rest of the meeting. Sorry.
No, we always appreciate your comments, Dr. Lane, and we appreciate all you do in the community. So thanks for sharing that with us. And yes, thank you, Dr. Sequeira and Heather as well. All right, now we're going to officially introduce Dr. Sequeira. I'm so pleased to introduce our presenter tonight, Michael A. Sequeira, MD, Public Health Officer for San Bernardino County. Dr. Sequeira received a Bachelor of Arts in Zoology from Pomona College in Claremont and graduated with his medical doctorate in the top 10% of his class from the University of California, San Diego School of Medicine. He completed his residency in internal medicine and emergency medicine at the University of Oregon Health Sciences Center in Portland. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 of its hospital emergency departments, including hospitals in San Bernardino, Apple Valley, Colton, and Redlands. He is past president of the San Bernardino County Medical Society in 2016 and 2017, yay! And currently serves as a delegate to the California Medical Association's House of Delegates through SBCMS. He's a member of the steering committee of the Inland Empire Opioid Crisis Coalition, where he's been instrumental in developing an educational program for opioid prescribing and overdose treatment and prevention in hospitals and the community. He also serves as National Risk Director for Vituity Healthcare, where he has been charged with keeping providers current with the latest clinical and research data on COVID-19. So with that, we are very excited and very honored to welcome you tonight, Dr. Sequeira. Take it away.
Thanks, Allie. I'm going to start with the screen sharing, and I really appreciate everyone coming tonight. And medical society meetings are always either in the evenings or on Saturday, so it's really difficult. And I'm one to really swear by balance and the importance of spending time with your family. So I appreciate you guys all coming on to this. And but I really appreciate it as a health officer. And when I came on as health officer from the medical society standpoint and from a county leadership, I knew that I needed to be out there and be more of a conduit and a resource for the physicians of this county. And so it's this kind of forum that I really appreciate, and it makes it easy for me. But it also allows me to be able to spread the word a lot more easily, and that's the job. That's my job as health officer. So I really appreciate you coming through. And today, what I want to talk about is these things. COVID always, everyone wants to hear COVID. I'm always going to give you an update on COVID. So I want to talk about the status of the infection within our county, the hospital situation. I want to talk about variants. It's becoming singular now, and give you an update on the vaccines, and most specifically about the boosts. And also want to, I want to throw in at the end of that a really cool new therapeutic agent. We actually have a therapeutic that's coming down that is showing a huge amount of promise. So that'll hopefully hold your attention until dinner. And then what I want to do after that is I want to tackle syphilis again and congenital syphilis. We've got babies that are being born, and it's a huge epidemic. And in terms of percentage growth, it's bigger than COVID almost in terms of percentage growth. And we've got mothers and just really infected with syphilis, not being treated and diagnosed correctly. And we've got babies being born with congenital syphilis, and it's very unnecessary. So it's really, really important. And the other thing is, I want to take a little time when we're talking about syphilis to talk about Title 17. And I don't know whether you all know it. I didn't learn it in medical school. It's Title 17 and the law about reporting requirements for communicable diseases, because it's really important that you guys know that, and it's important for your licenses, and these laws, Title 17, really the reporting requirements for physicians and hospitals and labs, but they're really important to make sure that we're notified, we at public health are notified, so that we can jump on cases and get our case managers and case study our disease investigators on the cases as soon as possible. So let's go to COVID real quick. I know my button's not working. So this is yesterday's graphics. So we've had 336,000 total cases. You can see this is the June July initial bump. This is the big bump that we had over the holidays, and this is the Delta bump here. And so you can see, and what's really interesting is what these are the deaths, and the case fatality rate is really quite low, and you can see the deaths here, and it's because Delta is hugely transmissible, but we're finding that the mortalities and the hospitalizations, especially with vaccinations, is just not as great. So fortunately, and our hospitals are some of the hospitals, especially in the high desert, are starting to stretch at the seams a little, but it's not all COVID, and I can show you that in a second. So the test, this is our testing. Remember, in February, March, we got on one of these and we said, everyone, we've got to start testing. And so, and the medical society was wonderful, and we really got the docs and the hospitals into testing, and we did a great job. And we're doing it again. You can see the testing again. And testing is also a function of contact tracing, right? Because you get one person who's positive or who's symptomatic, and then our contact tracers or investigators go out, and we're saying, everyone who's a close contact needs to be tested. So as our case rate goes up, the testing goes up proportionately. So you see that here. You see we're testing a lot more than even in December, January. But look at our test positivity is much lower. It's down to 4.5%. So you can see we're testing a lot more. And then this is a less graphic, but total cases, adjusted case rate is now 22.7. It's still like, if we use that old colored system, we'd still be red, but it's going down. It's going down for sure. And we got all the way up to close to 30, and now we're down to 22.7. And our positivity rate is 5.4, which is really quite good. And it's getting down in low red into orange. Everyone understands those colors, but so our positivity rate's down. It's partially because we're testing so much as well. But the positivity rate is the best lead indicator for what's going on. So just like in India, just like in South Africa, just like in some of the other European countries, the Delta provoked a really quick, big spike, but it's spiking down at the same time. And I think we're doing it quite well in California and in our county as well. So just speaking of the Delta, it's clearly highly infectious. It's more than 100% more infectious than the original virus, and it is hitting our younger population. But that may be a statistical aberration too, because we have more of the younger people that are not vaccinated. So it's hitting younger people, and it's hitting children too. So the people who get this have real high viral loads, and that's why it's so transmissible. And that corresponds to viral load, and CT values kind of are inversely proportional. So the higher the viral load, the lower the CT value. So just to kind of give you a guide of that. And the other thing is kind of 37 to 40 is the if it's below 37, it's definitely a significant and true positive PCR. And the CT values go to the PCR tests. So we're seeing really low CT values, high viral loads in the below 20 even with the Delta variant. And I put this in because I even talked to Dr. Pan, Jessica Pan, not Richard Pan, but our state epidemiologist. Our standard of significant exposure is a cumulative within 24 hours of 15 minutes where you spend time at 6 feet or less with a person who might have had COVID. So that's been the standard because it was based on a study that was done early on in January, February. So, but if you think about the increased infectiousness of the Delta variant, is it really 15 minutes? It's 100% more infectious than the original virus. It's probably not 15 minutes. It's probably more like 5 to 7 minutes where you get exposure. And is it really 6 feet, or is it really 12 to 15 feet? And we have no other studies with Delta variant to really help to define what significant exposure is. And that's part of the problem, because we've relaxed social distancing, right? We broke down all the barriers. People are going to the Dodger games and to the Ram games, and many of them start masked. And and if you think about this with the Delta and the definition of a significant exposure, that it's no reason why we're getting more and more cases. And we found too that the Delta has a shorter incubation period, 2 to 3 days, and longer shedding too. So that's why it's so much more transmissible. Among the vaccinated patients, even in our county, we're getting 10 to 15% of those of the infected people are vaccinated. But our vaccinated patients have a much lower hospitalization rate and much lower death rate. So it's still, the vaccine's still working. And there's some studies now, like the Israeli study that basically have started to show a little bit of waning at about six months with regard to the vaccinated patients, especially of high risk. And we'll talk about that with regard to the booster, but that's what stimulated the booster for the immunocompromised patients. So I wanted to show you this, to show you the dominance of the Delta. Look at here's Delta in the middle here. In March, it wasn't even around, 0%. In April, it was 2% of, these are our in our county, whole genome sequencing of all the variants. And you can see now, as of September 21st, it's 100% of all the viruses that we're doing whole genome sequencing. So it's completely taken over. So you've probably heard about the Mu variant. You probably heard about the Lambda variant. The Mu is this kind of scary looking variant. It's got over 20 mutations, and we've got one that was found in the South. There's only 154. This is the Mu variant in the whole world. But it's scary because it has a number of different scary mutations. But there's another variant, the C.1.2, that you'll see that also has a number of different significant mutations. The only good thing about the Delta is it's so dominating that it's keeping down all the other, it's just eliminated the competition. So that's the one good thing. And remember the Bay Area variant. The Bay Area variant was the Gamma, and we're not seeing it anymore. And we're not seeing the Alpha, which is the British variant, or the Beta. So the Delta has dominated, and it's just an amazingly stark and graphic illustration of that. So I wanted to go to boosters now. And I alluded to this, that we were one of the reasons is there was a study in the New England Journal about people with immunosuppression, the people who had cancer and were on chemotherapy, the transplants who are on immunosuppressant drugs, people on immunosuppressants like prednisone, azathioprine for their autoimmune disorders, and people with inborn disorders of immunity. Those are the people that it was noted that the effectiveness rate of the vaccines was starting to creep down, and the infection rate and breakthrough infections were starting to creep up. And they never really basically were able to mount significant neutralizing antibodies. And remember, neutralizing antibodies aren't the true test of true immunity to a virus. It's really the T cell function is anyway. But anyway, it looked like it was creeping down, and that's when and we heard all along from Pfizer that a boost was going to be necessary. A boost was going to be. We heard it every week from Pfizer, right? And then the Biden people came on and said, well, yeah, we want boosters by September for everybody. And so you've got to kind of filter out where you're hearing all this stuff about boosters. But the first thing was the ACIP and actually the research panel for immunization practices, and Dr. Hogue at Loma Linda is on that, by the way. But they started to look at the data for immunocompromised patients, and they saw that yes, there's probably a need. Let's do that. And that was 2 weeks ago when we released it for 2.5 weeks now. We released the third shot boost for immunocompromised patients. So that was instituted, and then the talk was, and we continue to hear it from Pfizer. We continue to hear it from other political issues about the third shot boost for other people. So as of the 17th, the ACIP and the FDA then looked at it and decided to release it such that all those who basically are 65 and older are now eligible for a boost, and at-risk patients who have multiple comorbidities, who are living in a congregate setting, either at a SNF or with a loved one, or and frontline personnel and care workers as well were also included. So right now, if you fall in any of those, you can go ahead and get your third shot Pfizer. Remember that Moderna hasn't yet been okayed for the over 65, but it has for the immunocompromised patients. Another question is, say you've had 2 Modernas or your 2 Pfizers, and you go to a pharmacy and you've had 2 Pfizers and they only have a Moderna. It's been okayed that you can have the alternate messenger RNA vaccine. So if you've had 2 Modernas and you go to a pharmacy or to a vaccine clinic or a doctor's office and all they have is Pfizer, it's okay for you to take the other mRNA. The Johnson & Johnson has not yet been approved for an extra shot. In their case, a second shot. Those of you who follow the news and the literature closely know that they Johnson & Johnson just released data today that showed a very significant increase in neutralizing antibodies and immunity with a second shot of the Johnson & Johnson. So that's going to probably be reviewed and probably be approved. It's interesting. There's no reason. There's a good reason why there's so much confusion about what's approved and what's not. It's because we have so many approving bodies. And within we talk about FDA approval, but then before that is EUA, right? The EUA approval is emergency use authorization, and that's also FDA. But before it gets to the FDA, it has to go through the research panel for vaccines and the ACIP, the American Committee on Immunization Practices. And then once it goes to the FDA, the FDA either goes EUA or complete approval, right? And the FDA approves. In California, it now has to go through California's scientific panel. So and that's before it goes to CDPH. So it has to go through the scientific panel, the Western States Scientific Panel first. If they approve it, and in many ways it's rubber stamped because you can, but this is the process, and this is one of the reasons why it's not just rubber stamped and rushed through. And it's really important that we get this message out. So it's got to go through the Western States Panel. It then goes to the CDPH, which then releases it and approves it for California patients. So that's one of the reasons why when we hear about boosts, Pfizer, remember, was talking about this 2 months ago. Everyone's going to need a boost, but and Fauci and the people with CDC and CDPH were saying, no, hold on, we don't need it yet. And then the study came out for immunocompromised patients, and then that had to feed into the ACIP, and then it had to feed into the FDA. And then the other thing that was confusing was there was EUA and full FDA approval, and we got full FDA approval for the Pfizer and so once FDA gives full approval, it opens the door much more from a legal standpoint for entities than to mandate vaccines, because it was really a lot of entities were business entities, et cetera, were a lot more hesitant to mandate the vaccination if it didn't have full FDA approval. So we've achieved that. All these are different multiple levels of approval, and it's important just to kind of mention it and go through it, just so that you know that you can actually properly interpret what's approved and what's not. So what's approved now is that the boost shot there, and I had an interesting conversation with Dr. Prasad just before this, and we talked about the boost versus an extra dose, and there is some confusion about that. And I did double research this, and right now what they're talking about in terms of a boost is a third dose, or the Pfizer or the Moderna. It's not qualitatively different in terms of it's not any different in terms of the messenger RNA components. But they are talking about a true boost, probably to be introduced in late September, early October, which is close. Now, where they're actually going to look at it and develop a whole a modified vaccine, messenger RNA, based on like the Delta and the other variants. But and that'll be the boost. It's like influenza. We get a boost every year based on the different H1, H and N phenotypes that we're seeing for the year. So I don't, I would anticipate this is probably going to happen, and they're so slick with especially the mRNA process, that they can really crank out a new vaccine and a new boost pretty quickly. And then once the initial one's been FDA approved, it'll really be a lot easier to move on to the second process in terms of approval. So keep in mind the CDC advisory panel, though, did not recommend boosters for everyone yet. So if you're on the front lines, if you're over 65, you're immunocompromised, yes, but not everybody. So that's it. Any questions on the boost, or we can open it up at this point. And I'm going to talk a little bit about this is the talk about the vaccine. We're going to basically, we're not done with the vaccination process. We reached 1.1 million in the county, and at least partial vaccinations we're in the mid 50%, but we still have a significant hesitance. I'm giving lectures. We're talking about hesitance, and we really need the physicians in the community to start reaching out, and we're going to hopefully get together something with the medical society in terms of being able to produce that. But we're still going, and we're probably anticipating with the boost a sudden increase in demand for it, but it's going to fall back down as soon as we get the people who.
Dr. Sequeira, you're on mute. Oh, okay.
Yeah, I don't know how that, it says the host muted me. Am I talking too much?
Oops, sorry if we did that. No, you're not talking too much. You love it.
Okay, any questions yet on the vaccine?
Sequeira?
Yeah, Dr. Lane.
Dr. Sequeira, this is Dr. Lane. We have 120 football players at San Bernardino Valley College. We have 60 that will not take the vaccine. I'm going to go there with pamphlets and passion to persuade the other 60 to get vaccinated. What I need is somebody from the county health department to be there to vaccinate those athletes. Now, I say that, but there's soccer and there's basketball, and there's swimming. There's a huge number of athletes that are politically against vaccinations. I will do everything I can to persuade them to get vaccinated. But at least for football, I would love you to be there.
If we can arrange it, and you can find a time, I'd love to be there. I think, Ken, one of the things that we can talk about is pro athletics. What's interesting is for pro football. I don't know whether you're familiar with that, but I am. They issued basically an indirect mandate, so that if a game it has to be canceled because of a COVID issue, the players lose their salary for that game.
Yes.
And the team has to pay for it. And just basically by putting that kind of
you can't get in the stadium in Las Vegas without a vaccination.
Right. And as of September 30th, that's going to be the case in Los Angeles County as well. But
if I could have somebody on the date appropriate,
you got it,
to vaccinate our football players, you'll get a Christmas card.
Right. And those of you know, we do work quite closely with Cal State and the UCs, and they're mandated as well at all Cal States. And I would hope that our community colleges could get a mandate through as well.
Bless you. Bless you.
Hey, Dr. Sequeira, I don't know if you saw, there are a couple of questions in the chat from Dr. Frausto and from Commander Morse. I don't know if you want to answer those now or if you want to wait. It's up to you.
Sure, we can do that.
Okay, great. So here, I'll read this for everybody. From Dr. Teresa Frausto, do you have to be over 65 and be a healthcare worker to get the booster?
Officially, yes. Remember though that you can, we're going by self-attestation with regard to the immunocompromised, but any frontline worker can and care worker and Teresa, I don't know which specifically, just a general person who's not a frontline worker or healthcare worker, but that's currently what's officially approved for, and the immunocompromised. I know a number of people. You're not going to get challenged if you just said, I have an immune disease or I take prednisone all the time. But I didn't say that officially. But
you're on mute, Dr. Frausto. You're on mute.
Thank you. I was wondering if you had to be both, if you had to be over 65 and a healthcare worker.
No, it's you don't.
Or.
Yeah,
okay.
It's either or. Okay. And I really encourage, we're having so much trouble with fire, police, nurses. Fortunately, physicians are I'm very proud of physicians. The rate is over 90% in the county for vaccinations. But our nurses and fire, EMS, we've really had difficulty getting the state mandate for healthcare workers applicable to EMS, and the state is still yet to extend that mandate. But now that the recall election's over, I think we may be seeing a little bit more action in that regard. But so, Heather.
There's one more. Can you clarify on the misinformation of boosters at 8 months versus 6 months after the second Pfizer?
Yeah. So it was initially thought, it depends on the study that was clarified that, that there was a kind of empiric statement that at 8 months, and this is actually the president said that in his release, that he was in general going to recommend that by late September, at 8 months, everyone was going to be recommended to have a third shot boost. But then the studies have shown with it, especially with the immunocompromised patients, that there's a little bit of a wane at 6 months, and the Israeli study also showed that. So there's still adequate resistance, and there's still the remarkable effectiveness at 6 months. But so there's a little bit confusion. It's not, there's no hard line on 6 versus 8 though. And I think we're probably going to go with the 6 months if it gets released to the general public. But.
Okay, that's all our questions.
I could be wrong.
Dr. Sequeira?
Oh.
Dr. Sequeira, this is Dr. Prasad. Can I ask one quick question?
Hi, Dr. Prasad. Yes,
Dr.
please.
Prasad.
One quick question is, now that we know that the booster dose, the so-called booster dose that we currently have, is the same formulation as dose number 1 and dose number 2, what I understand is that the Pfizer dose is the same volume, whereas the Moderna is half the dose. Does that make sense, given that both of them are mRNA vaccines?
Yeah, I know the Pfizer one for sure is the same dose, and there have been a couple of studies. I think again confusion of half dose Modernas, and I think it's been approved for full dose, their dose as well. The standard is not to give half dose, but.
So the booster dose for Moderna is the full dose, not the half dose.
That's my understanding. Yeah.
Okay. Thank you.
Mm-hmm. Okay, great. Okay, now let's talk therapeutics. We don't talk about therapeutics much, mainly because it's got to be vaccination. The only way out of this pandemic is vaccination. So we've got to keep pushing it. We've got to push it with our patients. We've got to continue to push it for ourselves. But I wanted to talk about a couple of good new therapeutic options, at least for your patients that do end up getting COVID. And one of them is monoclonal antibodies. First off, they work. They work really well, actually. And they work so well that the South especially has created a national shortage. Many of the southern states, especially like Florida, would prefer to use monoclonal antibodies rather than vaccinate and use masks. So there is a national shortage. We've had to, in California, we've had to fight for that, for our share, and based on our COVID burden, which is the lowest in the country, but it's still, we do have products. And I wanted to clarify and just briefly mention the 3 different products that we have. The first one now, and the most prominent one, is the Regen-Cov. Okay, this is casirivimab and indevimab. Okay, and this combination has been shown to be extremely effective, and I expand it down here. There's a greater than 76% effect in treatment for early, mild, and moderate COVID, and it's definitely been shown to be effective against the Delta variant. So it reduces hospitalizations, it reduces death, 76% improvement. But the other thing it's been approved for is post-exposure prophylaxis. So you're in a congregate setting like a skilled nursing facility, and the roommate gets, it turns COVID positive. It's been definitely shown and approved for post-exposure. In other words, you don't have to give it to a patient who doesn't have COVID. In other words, if they're exposed, you can give it, especially if they're high risk. The other thing that Regen-Cov has been approved for is subcutaneous. So, these other 2 basically require IV infusion, and it's a fairly complicated process for you to put an IV in, and it takes probably up to 2 hours per patient. And so it really sludges up, the emergency departments, and the state has been helping us to try and set up infusion centers for the monoclonal antibodies. So, the Regen-Cov has been approved for subcutaneous, and it's 4 shots. But it works, and so that's the big new thing for Reg and COVID, and one of the big reasons why there's a national shortage. But I definitely, we are getting some public health, and we just got a shipment of 125 vials of the Reg and COVID and 25 of the BAM-EDI. BAM-EDI is bamlanivimab and etesevimab, and this is the original Lilly product. And you remember it was pulled off because it didn't work so well in the British variant and didn't work so well in the original virus. But the amazing thing is they bothered to test it against the Delta, and it works on the Delta. So it's been brought back largely because, thankfully, because, we're running short on Reg and Co. So the BAM, we just call it BAM-EDI because it's so darn hard to say, the whole, I can't tell you how many times I've said this, trying to pronounce this smoothly, and I still can't pronounce it smoothly. Bamlanivimab and etesevimab. But so it's I think it's the Asian in me, but but BAM-EDI, just remember it as BAM-EDI. But the nice thing about BAM-EDI is it's also been approved for PEP, post-exposure prophylaxis, and it works on Delta, but it does have to be given IV. So both these you can get free from the state through us. And we've got all those vials right now at Arrowhead Regional. We're going to do basically, I'm sending out something through HASC to ask which hospitals are interested in storing some of these vials, because I think we should use up every vial of this to, just to keep our hospitalizations down. And in the shortage situation, what's recommended at this time is to use the monoclonal antibodies for patients who truly have it, mild to moderate, rather than post-exposure. If you have enough and we have extra, let's use it for post-exposure prophylaxis. And then on those people who have mild to moderate, those people who are at higher risk, who have the comorbidities. So it's all a game based on supply and demand. If we've got a lot, give it all the way through the people who need post-exposure prophylaxis. But if right now we've got the product, and last time we had just the BAM. We still got 75 vials of BAM here in our refrigerators that are not used, and there's no use for them because it doesn't work on Delta. Just bamlanivimab by itself. So let's use it, but let's run it to where we need. We have a shortage of it. So I'm announcing it now, and we're going to send it out. But right now, if you need any, Arrowhead has the county supply, and it's open to anyone who requests it too. And you can just go straight to the pharmacy at Arrowhead if you need to get this at this time. So remember monoclonal antibodies. It's really hot right now, and it's hot especially in those states that have the lowest vaccination rates and where COVID is flaring. But there's no reason, and we're still getting cases and we're still getting breakthrough infections. So and that's the other thing, is if we're in real short supply, it's recommended not to give monoclonal antibodies to vaccinated patients who have breakthroughs, unless they're really high risk. So it's all judgment and medical judgment and balancing of risks. Okay, so remember the monoclonal antibodies. It's an important thing. And my next topic is something that's really cool, and it's going to be new for a lot of you. And we've actually got an antiviral coming down the pike, a therapeutic, and that is molnupiravir right at the top. Molnupiravir. It doesn't have a brand name now. It's an oral drug like Tamiflu, and it's just actually pretty genius. It works on the RNA polymerase, which is basically the RNA polymerase is what allows the COVID virus, which is an RNA virus, to replicate. And it basically sterilizes the COVID virus. It makes it, in the scientific term, it makes the virus replication incompetent. it's a process called gene silencing. It actually incorporates into the RNA that's being made, and it creates the error where it can't replicate, it can't reproduce. So the initial studies show a marked reduction of COVID positivity in 5 days compared to controls. And there's a marked reduction in transmission as well. And the other amazing thing is it's the same technology, same RNA viruses. So it's likely to work on influenza, Ebola, and many other viruses. And it's been quite successful so far. There's a lot of excitement about this. And it's just been approved for phase 3 trials. So molnupiravir, keep an eye out for it, and hopefully we'll be rolling it out. And if we can get vaccination, and the use of our monoclonal antibodies and everything together, I'm really very optimistic that our science is going to catch up if our general public allows it to catch up. But so molnupiravir is all the virologists are really excited about this agent. So keep an eye on for that. So I wanted to stop at that, and then we'll go on to my next pet topic, which is syphilis. This is a boy, and this is not Tuskegee. You can see he's light pigmented, who had congenital syphilis. And this is what congenital syphilis does to babies and children. So what's happening right now is we are in the middle of a raging epidemic of congenital syphilis and syphilis in our community. This is the number of congenital syphilis cases. And as of 2020, it's gotten worse. So it's a 1,200% increase from down here from 14. And this is early syphilis rates. And this is just per 100,000 women. That's really gone up. This is our congenital syphilis rate. And this is 18 up to 18. You can see the rise in congenital syphilis and early syphilis. And then our county is big time involved in this. We're one of the hot states. Here's Riverside County as well. It's big in Riverside County, LA County, San Diego County, Orange County, and actually Ventura as well. So it's big down here in Southern California, and it's epidemic. So this is stratification by sex. This is the female rate. This is the total, and this is the rate in. Question, or is that someone broke? Okay. These are our hotspots in our county. Big time. This is dense. This is sparse. The blue. In San Bernardino, Ontario, and this is 18. And high desert. Interesting. Same kind of hotspots for COVID, but there are a lot of our lower HPI quartile 1 population, and these are our partners in Redlands, Esri, that help us do this. It's really pretty cool, these hotspot maps. So I'm going to briefly. I'm going to presume everyone knows syphilis, but everyone knows it's a spirochete. I'm going to go through these really quickly, it's transmitted sexually, vertically from mom to baby, and through the blood as well. And the primary lesion is this painless sore. Okay, there's one of the problems that we're having is being able to stage syphilis. There's primary, which is the initial infection, secondary, which is where it spreads to the rest of the body. You get rashes, and then late stage where it affects heart, brain, and the nerve system. And there are a lot of complications. And so here, this is the example of, the chancre is a painless sore. And it can be, in the genitalia, penis, vaginal labia here, they're painless. And they appear this is where the syphilis actually enters the body. And if you look, they're just teeming with the spirochetes with it. And the person is particularly infectious during primary syphilis, and it's 30% is through a contact, and then perinatal transmission is highly likely, 70 to 100%. And then we got secondary. Okay, secondary syphilis is 3 to 6 weeks later after the primary chancre, and it spreads through the rest of the body. You can see all the lesions here, and you can get meningitis, hepatitis, arthritis, and nephritis too. So these are the palmar plantar lesions. We're taught to always consider secondary syphilis, and then these are the condyloma lata as well. So in the vaginal rectal area, and then there's latent. Okay, this is important because people don't understand. After secondary phase, the infection becomes latent, and relapse is possible. And there's early latent and late latent, and I'm going to go through that. There's the early latent is within 12 months. Okay, this is the asymptomatic period. And this is where we're hopefully screening pregnant women, especially, and we're picking up, we're getting positive syphilis tests, and if you can track it to, oh yeah, it was negative just 8 months ago, and they're asymptomatic now, then yeah, that's an early latent, and it's treated differently than late latent, and that's part of the problem because late latent is not being treated well in our community, and relapse, of course, of secondary syphilis can occur in the first 12 months anyway. So this is really important in terms of a realization of the latent syphilis. 30% will go to tertiary syphilis, which is basically the gammas, which are the inflammatory granulomata that are in various organs, and it has a predilection for the media of the aorta, and it causes aortitis and can even cause aortic rupture, and then it can affect the central nervous system as well. And I'm just going to quickly go through this. And we definitely are seeing neurosyphilis. It can occur at any stage, and you can see that this marked atrophy and dural thickening that we see with neurosyphilis, and it definitely can be fatal. And we've actually seen 3 ocular syphilis patients in the last 2 years. Really thought to be rare, but we're seeing it. So I wanted to briefly go through the testing because there's a lot of misreads and mishandling of tests. So the old traditional way is we got RPR or VDRL, and one of the errors and problems that we get now is we don't get the quantitative. So we just get a VDRL or an RPR, which is a qualitative, and it doesn't mean much. You have to get the quantitative, and if it's negative anyway, it's sensitive, then you can relax it. It's not syphilis. But if it's positive, then you've got to do what's called there's 2 different treponemal or 3 different treponemal tests. You got to do it with the more specific treponemal test, the TPPA or the EIA. So, and if that's positive, then that person has syphilis. If it's negative, then syphilis is unlikely. What's recommended now, the problem with this is it misses early and early latent and in old treated syphilis. So what's recommended now is just called the reverse sequence, which is doing this EIA or a treponemal test first, which is very sensitive. And if it's negative, then you can relax. If it's positive, then you need to confirm it with a quantitative RPR. Okay, and if that's positive, then they have syphilis. If it's negative, then you need to do it again with the other treponemal test. And then if that's positive, then that person either has very new, early, or old infection. And then if it's negative, then syphilis is unlikely. And this is the way we can, it's a little complicated. And if you have this positive and all the others negative, it's recommended that we repeat it in 2 days to make sure it's not a real early new syphilis infection. Dr. Veltman said she saw an ocular syphilis. Wow, nearly every month, that is, and she saw one today. It's amazing. That's why I'm going to keep hammering on this. We need people like Dr. Veltman just to get this out, we've got this epidemic going on. So this is important, this reverse screening. Let me talk about congenital syphilis, because it's from the mother, it's to the child, okay? And it's what we call vertical transmission. And any stage of the disease can cause this. It's more in the primary and secondary. It's very preventable, and that's the tragic thing, is it's very preventable, the timely diagnosis. And so we separate early congenital from late congenital. Early is we can diagnose it within the first 2 years, and up to 40% of babies with untreated syphilis are born stillborn, and we see that in our fetal infant mortality reviews, and they're frequently asymptomatic presentations. But congenital syphilis, it has a pretty characteristic syndrome, and I've got great pictures here. They get these snuffles, they get these cutaneous lesions, they get a kind of desquamation or peeling with this maculopapular skin and throughout their soles, though, their palms and face. And then they get this rash, and then they're very characteristic bony lesions. And Loma Linda does a great job when we have a potential congenital syphilis. We send, most of our hospitals send those patients to Loma Linda for diagnosis. And there's very specific workup for these babies, and they need to have a lumbar puncture, a bone survey, and as well as laboratory testing. So this is early congenital. Late congenital, they get these are so-called Sabershins, where it's just periostitis and hypertrophy of the bone of the tibia. The Hutchinson's teeth, I don't know where that picture went, but they get perforated hard palates and iritis as well. So, there's a Hutchinson's teeth, kind of notched incisors. And I'm not going to go through this, but this is basically the algorithm, and this isn't up to date. I just pulled it right from up to date on what to do with maternal treatment and how to diagnose the baby. You can't get cord blood; you have to get baby blood. And if the titer is the same or less than fourfold, then you give simple one-shot treatment. If it's greater than fourfold or any question, then we give IV penicillin. But this is more simple, and what I want to stress. So early syphilis can be treated, and it's in primary, secondary, and early latent, less than 12 months, with benzathine Pen-G. It's 2.4 million units IM, single dose, and it's so important. Late syphilis, either late latent, you're asymptomatic, you can't trace it. It's been likely more than a year, or unknown duration. You've got to just treat it like it's late latent, okay? Or if it's known greater than 12 months. And it's treated with the benzathine Pen-G is the depot, and it lasts a week, okay? So what we've got to do is we've got to give 3 doses of the 2.4 million units at 1 week intervals, and they're at 1 week intervals. The recent CDC has allowed it to maybe relax up to 9 days, but the reason for that is that we've got to maintain the blood levels. These are slow growing. They're in the gummas, especially late latent. They're kind of in dormant phase, so we've got to maintain therapeutic blood levels for 3 weeks. We've seen mistakes where either ERs or urgent care say, "Oh, look, they've got 3 shots," but the first shot was a month before the second shot, and the third shot was 2 weeks after. If it's not at the 1 week or at the most 7 to 9 days.
I think Dr. Sequeira froze for a moment. Let's give him a moment to get his system going again. I'm going to text him to make sure he knows he's frozen. Uh-oh. Looks like we lost him. While we're waiting for him to rejoin, does anyone have any comment they'd like to make? Dr. Veltman, did you want to tell us anything more about what you're seeing?
Well, I think every single patient in my afternoon clinic had syphilis today. So,
oh, you're kidding.
I had ocular syphilis, a palmar rash that was syphilis. I had a pregnant woman with syphilis, and then alopecia from syphilis. So,
oh my goodness.
So it's very real. Lots of syphilis right now.
Do you usually know when you see the symptoms right away, or do you have to wait? Are you unsure what's going on and then you get the blood test back or whatever?
There's sometimes when it's just so characteristic that there's really not a doubt that it's syphilis. So yeah, sometimes you wonder, some of the macular papular body rashes, you kind of wait. Yeah. So.
Wow.
Mm-hmm.
Wow. It's unbelievable. Why do you think it's spreading so badly right now in this, I guess in any area, but in this area?
The patients that I saw today, I'm not clear if they got, about half of them got it sexually, but the other half, I'm not sure if it's from sex or through IV drug use. So the other two haven't been active in the past like 3 or 4 years, but they had secondary syphilis. So I'm wondering if it's in some ways related to the, concurrent drug use epidemic that we also are seeing in our region. So
wow.
Just based on my N of 4 today, but yeah.
Well, yeah, that's really amazing just from a, personal standpoint, testimonial.
Mm-hmm.
It's very frightening. Thanks for sharing that. That's interesting about the drug use being a potential factor in this.
Yeah, I do wonder if that's related.
Yeah. Dr. Sequeira is just about to rejoin. He got a little bit stuck with his technology. So while we're waiting, does anyone else have experience in this? Since we're on the syphilis topic right now, is anyone else seeing this or have any experience you want to ask or comment on?
I just want to say, and I work in an emergency department, and anybody that gets lab work, we include screening for hepatitis C, HIV, and syphilis. And I would say, honestly, at least 3 times a shift, we have people that have no symptoms and have never been treated and are positive for syphilis. And so it's very real. I agree that the symptoms tend to be classic when they're presenting, but a lot of very impressive cases in our younger and our older population, and our higher risk population, I guess I would say.
Wow, that's amazing. So there are no symptoms being shown or manifested in any way. So they get a blood test and it comes back and you detect it through that.
Yes, because the high levels we're seeing in our county, and CDC had made recommendations about 6 years ago in our ER, we started screening everybody that's already getting labs, running an additional test. And it's covered by their insurance, no extra cost to them, but we've definitely picked up on quite a few cases that we've needed to treat right away.
Wow, that's unbelievable.
Yeah, so it's very weird.
Yeah, and I think one of the clinical manifestations that I didn't really pay attention to that much until the past couple of years was mucus patches. And now that I'm attuned to it, I'm seeing it a lot more. So for the primary care providers on the call who do oral exams, the mucus patches are, I think, a lot more prevalent than we really realize.
Yeah. Well, and I think that's why Dr. Sequeira wanted to talk about that tonight. I think you all know it's an epidemic and that it's threatening our population. But I think his concern is that a lot of people don't realize this. It's surprising. You know, people think, he's talked about this before, people think of syphilis as something that existed back in the, you know, when I was a kid, you know, people used to talk and joke about syphilis, you know, in the 70s, 60s and 70s. And that's when the awareness rose about this. But I don't think people expect that it's going to be a threat to our public health at this point. So I know that, you know, we're kind of mixing several topics together tonight, but he wanted to talk about this because it's really important. He wants to be sure that all of our providers are communicating to your patients about this. Dr. Lane, you have a comment. Why don't you tell us what your thoughts are on this? Are you on, Dr. Lane?
I don't.
Well, okay. Anyway, Dr. Lane said it's a huge problem in Los Angeles as well. Okay. Well, I don't know. Dr. Sequeira just texted me and said he's trying to get back on and asked me if I can tap dance. And I said, no, I can't do that, nor would any of you want to see me do that. So, so I'm not going to engage in that sort of entertainment for you all at this time. But if you want to hold on just another minute, I think he'll be back on any second. I know you guys all have some great experience. Does anyone else want to share? I mean, we've got 22 of you on, and you've all done amazing things, and you have some amazing patient experiences and clinical experiences. Do you see any populations that are impacted by this? If you want to talk about COVID, we can talk about that too. How about you, Dr. Case? I see you.
Yeah,
I see you there.
So Allison, a couple years ago, Dr. Roger Sequeira had gotten Mitchell Goldstein to talk to us pediatricians in the high desert about congenital syphilis. Mm-hmm. And the timing of all this is that when HIV came out and people buttoned their flies because they were scared to death because HIV was deadly. Uh-huh. So they buttoned their flies and didn't do sex. Mm-hmm. Once HIV became treatable and livable on there, then what Dr. Goldstein showed us, the same type of thing. In 96, syphilis almost dropped off of the face of the earth. And then as people are living longer and longer with HIV, then they're opening their flies again, and they're having sex again, and syphilis is going up. And the few congenital syphilises, which I've donated to Loma Linda urgently there, because they're in NICU on there. When we talk to the mothers, they don't know what syphilis is at all. They don't, but they're mostly lower income people on there. So syphilis is not a term that they know. So there's a lot of education that needs to go through to help with that lower socioeconomic class who, when you talk to them about syphilis, it's like you're talking a foreign language.
That's really unbelievable. That's interesting you say that, because I was just referencing when I was a kid in the 70s, and as school curriculum, kids were taught what it is. At least, you know, when I grew up going to school, and, you know, in grade school or the later grades and then into high school, you're taught what it is. So I wonder if it's not part of the curriculum now, or if some of those people, I mean, some of these lower income people, even if they didn't pursue their education, I'm assuming they were still in elementary school. But I don't know, maybe it's just the message just didn't take.
Nope.
Wow, that's interesting. Do you see, so you see some pediatric cases come in every so often with congenital situation?
No, these are born right at the chute. In other words, they come in, they're in a bad way when they're first born on there. When he didn't allude to it in this, it was mentioned on his slides, but when it talks about the large liver and spleen, that's what we see on almost all these ones. And that impacts their respiratory stats, because it's like trying to breathe against a brick wall on there, because their liver and spleen are so huge on there with that. And so they have a really difficult time, you know, with that. So that's kind of the biggest issue we face is that.
Unbelievable. Well,
Mm-hmm.
thanks for talking about that. Dr. Sequeira's back.
I tried to get on my cell phone even, and I had to completely restart my computer. I don't know. What was crazy?
I told everyone, no, I'm not going to dance, Dr. Sequeira. You don't want to see that. But we had a good discussion about what some of our providers are seeing with syphilis and things. So,
oh, really?
Yay, you're back.
I'm sorry I missed that. That sounds that's really interesting. But, well, great. At least there's discussion about it. We need to be talking about this so much more. Let me get
Dr. Sequeira.
Yeah.
Hey, it's Dr. Neguse. How are you?
Hi, Johnny. All right.
Hi.
Great.
Just real quick, I just wanted to make a quick comment if I could.
Sure, please.
Well, this is more of an observation, and I'm kind of being silly, but not really. I think the ER doctors have been responsible for keeping syphilis at bay for a very long time because we were prescribing azithromycin, a Z-Pak, for bronchitis.
Yeah.
And then suddenly there was this big drop-off of giving a Z-Pak for bronchitis, and suddenly syphilis went up.
Mm-hmm.
So I do wonder if we were, keeping syphilis at bay in San Bernardino, and maybe if that played any role at all. Do you have any thoughts about that?
That's a really interesting perspective, and I hadn't seen a lot about that, Johnny. But it's true because we were prescribing azithromycin right and left, and and by the way, we're seeing mistreatment of late latents with because some doctors in the community because it's in the Sanford Guide to give 2 grams of azithromycin. It's not effective for late latent. So
right. Thank you.
But really interesting. Good point about that. But okay, so where was I? I was all the way over here. If it's neurosyphilis or ocular syphilis, we've got to go with complete, big time with IV penicillin, 18 to 24 million units daily. So bicillin, interestingly, a number of the health plans still are denying this. This has been around for 40, 50 years, but bicillin LA. So please, if you check with your formularies and make sure that it's there, because we've actually had to take patients to our public health clinics, insured patients, because it's not been on the formulary. So it's important, and it's got to be the LA, the long acting. So with congenital syphilis, I'm not going to go through a lot of this, but when we went through that algorithm, if it's possible or probable or even proven infection, we've got to do the IV for 10 days, or we can do IM for 10 days. If it's unlikely or possible, with the cord blood, the baby's blood is less than 4 times the titer of the mom, but the mom's still positive, then we'll still give a single shot of the PenG, the benzidine PenG. So these are the issues that we're running across with our physicians, basically. So when you're using the original traditional algorithm, an RPR is ordered, but the confirmatory test isn't ordered. So we're basically the patient and our contact investigators are caught up in the air. So if you're going to do the traditional algorithm, make sure you order the RPR quantitative and also a treponemal, either the TPPA or the FTA abs. So it's important to do that because there needs to be confirmatory testing because we don't know, and you can't adequately stage. And as you've seen, primary, secondary, tertiary are differently treated than late latent. So. And then the other is a qualitative RPR is ordered, but no quantitative. So it's important if you're going to go with traditional algorithm, just order a battery of quantitative RPR and a treponemal test. The recommended reverse sequence, order again as a battery. So order the EIA and order the RPR, and then you can do the confirmatory test, the second treponemal test if it's EIA positive or RPR negative. So, and the other thing is, we're not repeating the test. If in this situation, your initial test was positive, the other 2 are negative, it could still be the early latent. So, So it's important to repeat that in 2 days. The other thing is we're not staging. You know, and those of us who took syphilis a long time ago, and with me, it was a long time ago, we're not staging it. And we're treating it incorrectly because we're not staging it. You wouldn't go to an oncologist and have them just treat your cancer. They have to stage it because, you know, the treatment really is predicated by the stage of the disease. So you've got to be able to root through the signs and symptoms and really look at the criteria for early latent. Otherwise, we're not going to treat it correctly. So and the treatment guidelines. So remember, in a pregnant woman, doxy can't be used. Doxy used to be a kind of it'll cover it for BID for 14 early latent or 28 late latent. But for pregnant women, it can't be used. So if they're allergic to penicillin, we have to desensitize them. And there really has to be those strict 7 days, and the entire series has to be restarted if the dose is missed after for late latent syphilis. And we're not evaluating our babies well enough. The reporting practices, the cases aren't reported because the provider's under the assumption that the labs are responsible for reporting. And I'm going to go through Title 17. The lab has to report, but also the provider has to report. And it is by law, your requirement to do that. The hospitals, if you're a hospital-based physician, will take on the responsibility of doing that reporting for you because they have the lab anyway, so they're going to report for the physician as well. But keep in mind, you as providers, as physicians, need to make sure that it's reported. And the other thing we're seeing because of COVID a lot is that there's discharge of the mother without testing and treating for the syphilis. So mothers are being born and they're being sent home really quickly because they want to get home with their newborns, right? Because COVID's everywhere in a hospital. So their mothers are being sent home before the panel's not being done, or the mother's tested at delivery and discharged before the results are known. And this has happened. And we've actually, on a few cases, brought the baby to Loma Linda to be treated because they were discharged from a community hospital and not treated because the follow-up tests weren't done. And then we've got difficulty with non-compliant cases. And so this just illustrates that, 25% have limited prenatal care, 25% have no prenatal care of these pregnant mothers with syphilis. And then there's 50% of these that basically have significant problems with social determinants of health and reliability. So big problem for that. And then in terms of preventing, know that there is a screening requirement and we got to do partner service treatment. And we have to link it to prenatal care. I'm going to go right here. This is the law, especially in San Bernardino County. All pregnant women should receive routine prenatal care, which includes syphilis testing and HIV, of course. And in California, it's required by law that pregnant women get tested for syphilis in their first prenatal visit. And women who are at high risk for syphilis in areas of high syphilis morbidity and mortality basically are required to be screened again early in the third trimester at approximately 28 weeks and at delivery. So that's really important because of the high endemic rate within our population at this point. So that's that. And what I wanted to do just quickly is brief you on Title 17. I apologize for the fuzzy slide, but this is just this is the Code of Federal Regulations. This is California, and under Title 17, it basically requires providers and laboratories to report all of these. And I would just go in and I would get in, just Google Title 17 CDPH, and you'll find this. Any operate non-communicable conditions like animal bites, Alzheimer's, lapse of consciousness in terms of DMV, you need to report it to us. And chlamydia is no longer reportable by basically, but remain by the provider, but remains reportable by the lab. And pregnancy status is now required to be reported when you report, your your symptoms and your infections. And so if you look, these are the diseases reportable within 1 day. And in this talk, we're talking about syphilis. That's all stages. And this gives you a list of everything, either by fax, phone, or CalReady. And CalReady is the online system. So no infant who leaves the hospital without maternal serologic testing determined basically should leave the hospital without the mother being tested at least once during the pregnancy and again at delivery. And if a mother presents at delivery with no prenatal care, then a stat RPR needs to be performed. And if a baby has congenital syphilis and is asymptomatic, then there's still an opportunity to treat the infant to prevent further morbidity. One last thing that we see is, and I'm going to go through some of the issues, is a young woman presents in the emergency department with vaginal bleeding, for instance, and one of the things we always do is rule out pregnancy. And if the pregnancy test is positive, that's the first discovery. That's the first trimester discovery. Basically, syphilis serologies and HIV need to be sent by the emergency physician at that time, and the emergency physician has to ensure reliable follow-up, even if it's just to public health. But until that mother sees a follow-up physician, that patient is the hospital's and the emergency physician's responsibility. So we see that a lot, and that's really important to emphasize, because again, mothers are slipping through the cracks. So basically, I'm going to stop it at that. Hopefully, there's a little bit more time. I'm available for questions. There's a lot of other things that I want to talk to you about. By the way, this is an excellent CDPH monograph. It just came out 2020. It's 38 pages on expanded syphilis screening recommendations. And just keep in mind, CDC just came out with their STD treatment of STIs as well. So in other topics later on in another forum, I'd like to talk about Candida auris, the new super fungus or yeast. I want to talk about heroin and our fentanyl epidemic. I want to talk about wound botulism, because we're seeing more and more about it with it. And we'll talk about botulism, and then opioid use disorder. So there's a lot of good new therapies out for opioid use disorder as well. Just want to kind of throw those out there to keep you interested. But we're thinking of doing a more comprehensive town forum on opioids as well. So I did want to open it up for any other questions or comments or sharing of experience like we did before. So I'm looking at and thanks Jennifer for in the U.S. azithromycin resistance is fairly high for syphilis. That's why it's not really recommended anymore.
So this is your chance, everybody. Do you have any questions for Dr. Sequeira? Feel free to raise your hand through the chat feature, or just speak up, whatever you'd like. About anything, about COVID, syphilis, reporting requirements, opioids. No?
Dr. Veltman, you came on.
I know.
I'd love to hear your comments. For those of you who don't know, Dr. Veltman's Chief of Infectious Disease at Loma Linda. She's very active in our public health community. So.
Yeah, no, thank you. So I do have a question about COVID for you. What are you doing with the public school or the private schools that are not willing to do mask mandates despite the California Department of Public Health order? And for any of the parents like myself who have kids in one of those private schools, it's such torture.
It is torture. And
it is torture.
It's this. We're handcuffed and we've been told to lay off. And it's only come in rescue if they ask for help. But it's really tough. And there have been outbreaks, and I won't name names because we're being recorded. But but it's tough because we you know, the private schools, like Jennifer was talking about, they don't report to us, and they're on their own, and they have these liaisons and who don't know contact tracing and don't know a lot of statistics. We're open to them, and if you know, if you have your children in private schools, you know, recommend that they call us, and we've got great school resources and guidance available. But it's frustrating our contact tracers as well. It's seeing that.
Dr. Sequeira, I had a question. Dr. Veltman gave a really good answer or some input on this. I was wondering why the spread of syphilis started up again a couple of years ago, how this has happened. And that's kind of what we got into discussing. And Dr. Veltman said there could be possibly a correlation with substance abuse and drug use. And we started talking about that a little bit.
Yeah, there are multiple variables in contributing. One is, you know, we lost contact with you know, the old safe sex thing, and in our 20s and 30s somethings too. You know, there's really a lot of indiscriminate sexual activity, and it is related to substance use. I think Dr. Veltman made a great point. You know, meth is rampant in our community, and so are opioids, and you know, people who are intoxicated basically don't do anything responsibly, unfortunately, and certainly when it comes to this. And then there's comorbidities, the mental health and drug use. So it's amazingly frustrating. We have these mothers who have had 7, 8 children, and you know, three with congenital syphilis, and they won't come back for the shots, and they're out in the community. And you know, we have some regulations that allow us to do civil detentions of TB patients, but we don't have that for syphilis. You know, and it may be something that we have to introduce as legislation, because there are very irresponsible patients out there, and it's kind of all snowballed. And a lot of it too is our CDPH epidemiologists and infectious disease people have said we've got basically two decades of doctors that really haven't had much experience with, you know, with the fine points of syphilis diagnosis and treatment. You know, the confirmatory testing, the necessity for the 3-shot dose, desensitization, and et cetera. And so it's all basically a compound summation of all these factors.
And Dr. Case actually had some comments too about when HIV, when it became more under control, you know, a decade or two ago. It seems like some of this also, the awareness and the treatment for things like syphilis maybe went by the wayside. And he said he'd had experience with some patients who, believe it or not, were not aware, didn't know what syphilis was, right, Dr. Case? Yeah.
Yes, that's true. That they had congenital syphilis cases born that we shipped to Loma Linda, and we basically had one of our nurses had to do a syphilis 101 with them.
Wow.
On there, because they knew nothing about it. On there. See, what Mitch Goldstein had told a group of us pediatricians was that when HIV was deadly, syphilis dropped because people button their flies. When HIV started getting treatable, a la Magic Johnson and others, and they're, you know, Magic's still alive, then people started letting go. And as you alluded, the no safe sex part, you know, they're just going rampant on there, and you know, but they don't know about syphilis until we come across, whether we do testing or like, you know, these situations here.
Yeah, we really great points. And you know, we're running more and more of these stages, the early and late latents, and physicians really need to realize, and you know, the treatment's different. My daughter is in the 20 age group, and part of this indiscriminate is that, you know, they have these apps, these hookup apps that, you know, the 20 somethings, you know, and they're in an area, they go to downtown LA, they get this hookup app, and it's whoever wants to have sex, and they just go in.
Oh my gosh!
Yeah,
really?
Yeah,
I'm out of it.
They connect up, and it's amazing how much is going on that way. So,
and the meth, like meth is not a lot of times used just as like meth. The meth parties are also sex parties. A lot of times they kind of come hand in hand. And my patients who are going to the hotels with the meth parties, they're having sex with like 7, 8 different people, like in that one night with that, so.
Oh my goodness.
Yeah, no kidding. So yeah, it's out there, and it's epidemic. So I've already given variations of this talk 3 or 4 times. I expect to do it a lot more too. By the way, some of the residents, Dr. Beltman, rotating through, have prepared something for the Loma Linda family practice and preventive medicine. So I'm sure they'll be involving you. But
oh, cool.
Yeah, because and I want to thank, Loma Linda is our only children's hospital, so that really rely on Dr. Beltman and the peds department at Loma Linda to take care of all of our congenital syphilis. So.
Well, I don't really see any other questions unless I've missed any. This is, I guess, a last call if anybody has anything. Well, all right. So with that was a really, really, as always, outstanding presentation. Thanks, Dr. Sequeira. And we'll, if you are up for it, we'll have to do another one of these, maybe a third in the series, as well as, like you said, maybe we can look at doing an opioid presentation. That would be great too, because you've been such a leader in that space as well.
I appreciate that. Yeah, and it's a good way to get things out. Like, it's Vibrio season, and our enterics are coming out, so we can do stuff on that, and botulism. We've seen like 4 cases in the last month and a half. So,
golly. Well, all right. That's
okay.
Good. Well, if you guys need anything, you know how to reach us at the Medical Society. And thank you again, Dr. Sequeira. And thanks to all of you for hanging tough during COVID and everything else that's going on. And we really appreciate all of you being so amazing and making sure our community is safe and healthy. So
great. Thanks, everybody.
Have a great week, everyone. Thank
Sorry
you
about
so
the glitch.
much. All right. Good night.
Okay, bye-bye.